It's my delight to be the chair of a panel entitled Chemical and Physical Restraints, Segregation and Surveillance Risks and Benefits. And I know the topic of restraint is of interest to many, many of us, and we are all committed to reducing the use of restraints as much as possible and improving the lives of persons in residential care. Our first presenter will be Leanne, then next Elisa Marie, and next Susan Madlung, and I invite you to read their bios in the folders that you've been handed out. Thank you very much.
Good morning. Oh, I have to have this up really high. It's good to see you all. Thank you for joining us. I'm here to set us up in our presentation, and I'm going to start by asking or telling you about my agenda. So I wanted to cover three things. Tell you about what is a restraint according to BC law, then talk a little bit about the law, and then talk about substitute decision making. So I think most people in here have an idea of what a restraint is, but according to the residential care regulation, a restraint means any chemical, electronic, mechanical, physical, or other means of controlling or restricting a person in care's freedom of movement in a community care facility, including accommodating the person in care in a secure unit. I'll just bring you back. So this is in Riverview. It's the oldest building at Riverview. So locked wards, our locked units are also considered restraints. And simply put, a restraint is a device or medication that is used to restrict a patient's voluntary movement. So the laws guiding the use of restraints in British Columbia are the Healthcare Consent and Care Facilities Admission Act, commonly known as the Healthcare Consent Act, because the care facility part is has not been proclaimed, as well as the Residential Care Regulation, which I'm sure you're familiar with under the Community Care and Assisted Living Act. The Healthcare Consent Act is part of a suite or a group of laws that we call the Adult Guardianship in British Columbia. And when at the Public Guardian and Trustee, which is where I work, and we're often asked to be a substitute decision maker, we look at these guiding principles every single day. First and foremost is the presumption of capability. There's also the right to self-determination, court as a last resort, and just enough support. And when we look at capability, it's something that you are familiar with. I mean, it can fluctuate on a day, it can fluctuate on the hour of the day, whether the person's had a meal. It can fluctuate depending on medications. I always think of it as a spectrum from 1 to 20, and it can be anywhere along that spectrum. So in British Columbia, who are the substitute decision makers? So these are the people that can make decisions on behalf of someone else. So a court-appointed committee of person under the Patients' Property Act. So the Patients' Property Act is that old, antiquated act that we're trying to get rid of, but we're still having to work under. And then there's a representative under the Representation Agreement Act. And then there's the Temporary Substitute Decision Maker, TSDM, just to shorten it, chosen according to the Healthcare Consent Act. So just as a reminder, so if there is no committee or representative that has been chosen by the adult, then the healthcare provider looks to this list of people in the Healthcare Consent Act, and it's for a temporary substitute decision maker. So it's specific to healthcare treatment being proposed at a given time. And this, you may recall, about a year and a half ago in September of 2011, this list was expanded. It was much briefer before, but it's including a close friend, which of course opens the door to many, many people to be able to help out. So I'll get into a little bit of the nuances around decision making. And this is kind of the tricky part. And I'll just kind of start by talking a little bit about the issues in British Columbia, because in BC there's no legal scheme to actually consent or agree to a restraint. So there's nothing that says that if there is no agreement, what can be done? And that's a bit of a loophole. There is law that exists, but it's not been proclaimed yet. So when I look at consent, that is specific to the Healthcare Consent Act. So if the restraint is healthcare related, So it's needed, required as part of a healthcare plan or a treatment plan. In order for the treatment plan to be effective, then that can be consented to under the Healthcare Consent Act. So you can think of an example of someone who's had surgery and, they're picking at the wound or something like that. So you need to restrain the person to not be able to do that so that they can recover. Then agreement is under the residential care regulation. And that is, agreement is when, or a restraint under the residential care regulation is specific to behavior. So it's when a restraint is used to control aggressive behavior or to protect that person from themselves or others. So it's very distinct. So the way I'm setting it up today is that there's restraints for healthcare purposes and restraints for behavioral purposes. And it's always important to think of what is the purpose of that restraint being used. So I have just another way of looking at it for people who like charts. I think it's helpful for some people. So just looking at the different authorities. So if a restraint is specific to healthcare purposes, again, specific to a medical treatment, any one of these substitute decision makers can consent or agree or consent to it because it's specific to healthcare. Where it gets tricky is when it's under the residential care regulation, and what it says under the regulation is that restraints may be used in an emergency, and when there is agreement in writing by a person, parent, or representative, and the responsible medical or nurse practitioner. So for a comity of person, they can agree to a behavioral restraint, or they can consent to a healthcare restraint. A representation 9 is kind of tricky because a representation 9 so that's where it's more broader powers than the representation agreement 7, which is more standard powers. They can, only if the adult says that they can give restraints for behavioral reasons in the representation agreement, can then the substitute agree to that restraint. And that's kind of tricky, and I think as a healthcare provider, the first thing you want to do is look at the agreement. If anybody says, oh, I'm a representative, ask to look at that agreement, read it, and see what does it say in there. What can that person do? What are they allowed to do? And if the authority is the temporary substitute decision maker or a representation 9 for standard, again, they can consent to a healthcare. If the purpose of the restraint is healthcare, they can consent to that. But if it's specific to behavior, there is no authority for a TSDM or a representation agreement 7 to agree to that. If you're ever acting as a substitute decision maker, because I think, it's kind of relevant for ourselves because we're having our aging parents and we're having to make these tough decisions ourselves. And of course, with the people that we're working with, I think it's important to always, and I'll repeat it again, to know what is the purpose of that restraint. Is that person who the restraint is being used for, are they capable of consenting or agreeing to it themselves? And looking to that person first. But these values and principles that I have up here are actually part of the residential care regs as well as the Healthcare Consent Act. And again, it's looking at what is the purpose, the least restrictive or last resort. So have other options been explored? What are the alternatives to this, to using these restraints? A staff training is an important issue. Are the staff who are administering or facilitating that restraint, are they trained properly? And then there's the reassessment. I had, our panel had met and we were kind of sharing some stories. You'll get some really good ones in a bit. I just have a couple that I wanted to share. I mean, we had a situation where we were asked to, well, initially it was consent, but we had to get into that discussion of consent agree, but a person was continually pulling out their feeding tube. And so the decision, this was in another health authority, not in the Lower Mainland, and they wanted to use a 4-point restraint during feeding so that the person couldn't pull out the tube. So that, I guess, was working for a little while, and then they wanted a re-consent or re-agreement. Anyway, the discussion ensued. But what was very curious about this particular restraint was that every feeding time, or, feeding time when the person was, that sounds terrible. Every meal time, breakfast, lunch, and dinner, the person would go assume the position. Right? And so it was curious because what kind of reassessment happened, right? What was going on? Was it still needed? Were there other options? So that's, I think, the part that I think sometimes happens, and that's where we get involved at the Public Guardian and Trustee, is just looking at those types of issues and consulting and providing some direction. Just to recap, in the residential care regulations, they look at some of the values are is it necessary to protect the person from serious physical harm, again, as minimal as possible, looking at the safety, physical, and emotional dignity of the person during the use, alternatives, and following instructions in a care plan. So that brings me to my last slide, I think. Am I good? Which is, I'll just tell you a little bit about a case study. There's lots of situations where we are asked to provide consent for a healthcare decision because there is no one else. And so we'll often get calls, even if there may be someone else, but the healthcare provider can't find them. So this is the story I'll tell you is just a simple one, actually, and it's about a person who we were asked to consent to their care plan and their MAR, their medication administration record. And one of the medications listed was administered daily to calm the person. And so, but there was nothing in the care plan that identified the need for any kind of restraints. And I think that is one of the, that is something that we see on a daily basis at the Public Guardian and Trustee, and I can imagine it's something that you're working with frequently as well. And what I think is important to note about that is that it wasn't, we were actually committee of a state and had no authority to we weren't a substitute as a committee of person, but the person hadn't discussed it with the family ongoing. So it was just that, here's the plan, here's the administration, here's the MAR, can you consent? And so what I think from a substitute decision maker's perspective is, what are the questions that you want to ask when you're presented with that MAR and when you're presented with that care plan? So we don't know all the names. I mean, we're going to learn a little bit, but I don't know all the names of all the drugs that are used to restrain a person. So I think that's a very good question to ask, is, are there any medications in this MAR that are used specifically to restrain this person, to calm them down, and why? And then that opens up that discussion. But I think sometimes that discussion may not be happening, at least we always get the kind of the worst of the worst calls. But I think it's also important for a substitute decision maker to know, well, what is the nature of the drugs? Why are they used? And the combination. And I think that's, it's just really just empowering the family and the decision makers, and the substitute decision makers to know, well, what are they looking for? What exactly are they agreeing to? Versus just having that long list, which can be very overwhelming for people. So I'll leave it at that and just set it up for a discussion about medication. Thank you.
Hi there, my name is Elisa Weatherby. I'm a clinical pharmacy specialist with Fraser Health. Currently I'm working at Oceanside, and basically when Riverview closed down, they had the Valley View wards, and those have been moved out most of the beds have been moved out to Fraser Health, but other places in the Lower Mainland, and I'm responsible for 3 places: Oceanside, Clayton Heights, and Arbutus Place. So today I'll be talking to you a bit about how we're using medications to manage problem behaviors in the elderly. I'm not so much focused on the legal aspects of it, but more of the practical things that we're seeing, and we can touch on the legal aspects too in the question period, and from what I experience in working in a team who prescribes the medications. So the outline is that I'm going to discuss medication issues in general, what we should all be looking for when we're prescribing medications or administering medications to patients. We'll talk about what happens to you as you age in terms of pharmacokinetics and dynamics. These are important things to realize, why medications don't work the same in elderly as they do in adults. Then we'll talk about some medication statistics in residential care. Talk briefly about the behavioral and psychological symptoms of dementia and their management. I'll touch briefly on mental illness, and then from my perspective, from a team perspective, how do we go about prescribing these medications when we actually have to prescribe them? There's no other alternatives in the elderly. So here's some objectives for today. So I want you to become more aware of what pharmacokinetic and dynamic changes occur with age. Explain why patients in residential care or your clients are at increased risk for experiencing adverse drug reactions. I want you to be cognizant of which behaviors do not respond to pharmacological treatment, because not everything we prescribe actually works, and to recognize what to monitor when you're using medication to manage these problem behaviors, because that's one of the points we often forget about. We put them on a drug and then we forget to monitor often. So in general, when we're looking at medication use in all patients, doesn't matter if you're a pediatric patient, an adult, or an elderly patient, we have to consider safety things. So when I think of safety, I think of how is the drug being processed by the body? What is the drug actually doing in the body? Like, what is the effect? And how does that change depending on the age of the patient? What type of ADRs is the patient at risk for, depending on their interactions of other medications they may be on? And this term called polypharmacy, you're hearing it a lot more now. There's a couple definitions out there basically saying that if you're using more than one medication for an indication, that could be considered polypharmacy, or just the sheer number of medications is also considered polypharmacy. So another thing I like to consider when we put someone on a medication is effectiveness. Is the medication actually working for what we prescribed it for? And if we don't have the information, and we're thinking about starting a medication on a patient for some problem behavior that we've deemed problem, is there any research data looking at this in the elderly population? Probably not, or very limited, so we have to consider that as well. And then the final thing I like to look at is the compliance. So overall, when you're prescribing medications, what is the pill burden? How many meds is this person actually on? Is the regimen very complex? Are you giving a medication 4 times a day versus once a day? All these things factor into the quality of life of the patient, and how the patient's going to respond possibly to therapy. So here's a definition of pharmacokinetics. For probably most of you may have forgotten what it means, but it's basically how the body is processing medication. And it's divided into 4 categories: your absorption, distribution, metabolism, and elimination. So absorption is how does the drug get into the body. Distribution is where does it go after it's absorbed. Metabolism is how does the body get processed or break down the drug. And elimination is how does the body get rid of it. Often you hear about renal excretion of drugs, and that's a main way of the body gets rid of medications. So what happens when we get older? Well, a lot of these things change, and it's not always good. So your absorption characteristics basically go downhill. You have decreased gastric secretion, intestinal surface area. Your carrier-mediated transport systems decrease. Your intestinal motility decreases. Mesenteric blood flow decreases. All these things, tissue perfusion decreases. So what ends up happening? So you give a drug. It takes longer for the drug to start working. And then often you have a reduced clinical effect. So I always get questions, well, I gave this drug a few minutes ago. It usually works in 15 minutes in the adults. How come it's taking like 3 hours? So think about that from that point of view. You're giving some medication. It takes a couple hours to peak now, and maybe the effect will last longer. Distribution. So as we age, we get an increase in total body fat, decrease in muscle mass, water. The integrity of the blood-brain barrier is less. You have a decreased amount of albumin, which is a protein that a lot of drugs bind to. So if you don't have a lot of albumin around, some drugs actually start going around freely, and you have increased risks of side effects as well. And there's also changes in certain transport proteins that remove drugs from various cells. So in general, we think of what the consequence of this would be. Fat-soluble meds linger in the body longer, more medication is passing into the brain, and higher medication levels circulate in the blood overall. If we look at metabolism, we think of the liver. Liver volumes change as you age. hepatic blood flow decreases, the enzymes themselves don't work as well. And when we think about what happens, the drugs aren't breaking down quite as well. And elimination, if we focus mostly on the kidney here, the renal blood flow decreases, GFR goes down. So what happens? The drugs stay in the longer and accumulate. And so this is why your elderly patient does not respond the same as an adult with the same dose of a drug. Pharmacodynamics basically is the way that medication interacts with its target tissue to produce the physiological effect. When you get older, there's a decreased number of receptors in various target organs. So when you're giving drugs that block certain receptors, like the cholinergic drugs or block dopamine, for example, you get a tendency to have more side effects. So the patients have more risk for side effects. Cells may respond differently to receptor occupation. Older individuals are more likely to get something called orthostatic hypotension, and that's because of the way it interacts with the alpha-1 adrenergic receptors. In general, as you age, you have a compromised homeostatic system, you have impaired glucose tolerance, cognitive reserve, orthostatic circulatory responses, thermal regulation, thirst responses, vascular stability. Basically, you have increased sensitivity and susceptibility to side effects from medications. So we know that elderly individuals are 4 times more likely to experience a adverse drug reaction. Patients living or people living in the community on medication, it's reported that up to 21% will experience an adverse drug reaction at some point, but up to 74% of those living in nursing homes will experience an adverse drug event. And if we look at this term polypharmacy, in this case, just looking at the sheer number of meds a patient's on, the more number of meds, the more likely you're going to have an ADR. So if you're on 2 or more meds, the risk of an ADR is 13%. If you go up to 7 or more meds, the risk of ADR is 82%. So when you think about, I'll just keep going. When you think about if someone's on 9 or more meds, you're probably looking more at like 100% chance of an ADR occurring at some point. So we have to consider the sheer number of medications as well. And then we think of the medications used to manage behaviors. Those are the meds, the psych meds, basically, your anti-psychotics, antidepressants, sedative hypnotics. Those are one of your categories of meds that has a huge propensity to cause interactions with other medications. And there's research showing that the psychoactive medications are, when you're using them, they're the most often associated with the adverse drug reactions. And they consider this a preventable adverse drug reaction. So we have to be cognizant of that as well. So here's some statistics I found about the use of medications in residential care in the elderly population. A U.S. study was published in 2010 based on data collected from 2004. It found that 40% of nursing home residents were receiving 9 or more medications. And in the study, they termed that polypharmacy. The medications that were most frequently prescribed, they found, were laxatives, things for GERD or peptic ulcer, pain relievers, antipyretics, and CNS meds. So the CNS meds, which we'll be talking about today, compose a large portion of what these patients were on. Risk factors for the huge number of meds these patients were on, they found was if you were female, Caucasian, Medicaid was your primary payer. You had more comorbidities. You needed assistance with a certain number of ADLs. If you were in a facility for 3 to 6 months, you were at the highest risk for polypharmacy. And actually, if you were in a small, not-for-profit facility. So that's an interesting thing to consider as well. Cochrane published a review in 2012, and they also looked at polypharmacy in the elderly. And they listed another possible reason for it, clinical guidelines. So how many times do you look at your clinical guidelines and try to extrapolate them to your elderly population? So a person might have CHF, hypertension, diabetes, and the list goes on. So a lot of practitioners are just trying to implement all the clinical guideline recommendations, and that in itself ends up, the patients become are put on many, many more meds maybe than they can tolerate or should be on. A study in Australia also looked at patients in residential care who had dementia, and they found the average number of meds was almost 10. And this included all your OTC things and herbals as well. And a snapshot showing that 30% of these patients were also prescribed an antipsychotic. In 2009, a Canadian report found that 53% of patients in healthcare institutions were taking 5 or more medications. And if we look at BC PharmaNet data, which is available on the ministry website, they have shown that 50% of patients in residential care have been prescribed an antipsychotic between April 2010 and June 2011. So I just wanted to give you a snapshot of what's out there and what we're seeing in terms of medication use in the residential care setting. So I'm not saying that you should never use medications to manage problem behaviors, but we need to know when it's appropriate to use them. So it depends on many factors. The diagnosis, you have to determine, is this a delirium, dementia, mental illness? We treat these things differently, or we might treat them the same, but we have to know what we're treating. You have to look at the type of behavior. Is this behavior actually putting someone at risk or others at harm? The comorbidities the patient has, and then look at the safety issues overall based on the drug data, the evidence for that medication, and have we tried other things besides the medications first? We have to balance the risk versus benefit every time. So as we know, there's many different types of dementia, Alzheimer's, vascular, Lewy body. You also have to know, just like I said before, the diagnosis, because certain different types of dementia require different treatments. As a reminder, Lewy body dementia, those patients are very sensitive to antipsychotic medication, and we try to avoid where possible at all costs. Okay? So you have to know what type of dementia you're dealing with as well, because treatments change depending on it. Here's a list of the behavioral and psychological symptoms of dementia, anywhere from agitation to inappropriate vocalizations. Everybody should be aware that not all symptoms respond to medication. So wandering, hoarding, inappropriate voiding, repetitiveness, calling out, inappropriate vocalizations, those symptoms typically do not respond to medication. So when the nurse says, oh, this lady's calling out all the time, and I keep saying the medication is not going to work, it's just going to put her to sleep, and then it doesn't really do much in terms of the actual behavior. So we have to consider not putting patients on meds for that. Your first step in managing BPSD is basically to identify the target symptoms that are a problem and initiate your non-drug treatment plan. So you have to address, you've probably heard this over and over, address the physical, intellectual, emotional, psychosocial, and environmental triggers, including their unmet needs. Is the patient in pain? Do they have something wrong with their bowels today? What other medical conditions are going on? Is there boredom, loneliness, noise levels? The timing of the care issues? There's so many things to look at before we start medication. So you really only want to be using the pharmacological treatments when you've exhausted all the other non-drug treatments. And when there's a risk of harm to the patient or others, and the symptoms are causing the patient's distress or suffering. So the agents that are out there that we're using are typically the cholinesterase inhibitors, things like memantine. Those actually may reduce the severity of existing behavioral disturbances, agitation, aggression, irritability, but they don't necessarily always help with depression, apathy, anxiety. So that's when you'll see patients not only on these agents, but the physician may also prescribe things like SSRIs or other antidepressant type medications. So if we look at the Canadian consensus guidelines for the diagnosis and treatment of dementia from 2012, here's some caveat points. Even though we're using these medications to manage these behaviors, there's still insufficient evidence to recommend for or against use of SSRIs, trazodone in agitated patients. Okay, so we still don't know. Now they're saying valproic acid shouldn't be used for agitation and aggression in Alzheimer's dementia. The studies show that it doesn't really work, and it just increases the risk of serious side effects. They're saying that if you have to use an antipsychotic, they're advocating risperidone, olanzapine, or aripiprazole based on some studies for severe agitation, aggression, and psychosis only. That being said, you really don't want to go to these drugs unless absolutely necessary, because we know that there's a risk of harm to the patient, increased cardiovascular events, and overall mortality. This data came out in 2005, studies looking at antipsychotic use, the atypical antipsychotics, the newer antipsychotics, and they found that in elderly patients with dementia increased the risk of overall death and cardiovascular events. So Health Canada put out a warning, along with a lot of other jurisdictions around the world, including the US, Europe, that we shouldn't be using these drugs in general for these patients. And then I remember working as a student in one of the wards at Mount St. Joseph's, and this study came out, and one of my physicians started switching everyone to conventional antipsychotics, and then a few months later this study came out saying that they're just as bad, don't use them. So we have to be very careful with what we're doing when we're jumping to, even if there's a health warning. So if we talk a bit about mental illness in the elderly, there's other things we have to consider. Just as you get older, you don't lose all those other conditions. So if you were a depressed person through your life, you may have depression as an elderly person as well. So this is just a slide outlining that patients are also on other things as well, not just for dementia. So you have to really know what they're on and know the risk of each of those drugs. So from my perspective, how do we prescribe medications in the elderly? Well, firstly, from a team perspective, I always ask when we're trying to manage a behavior, could any other meds be contributing to the problem? So I review the whole profile with the physician. And then we simplify the regimen where possible. We identify the target symptoms and goals, and we try non-drug measures first. We consider the benefit versus risk of using the medications. And if appropriate, and only when absolutely necessary, we initiate the meds and start at lower doses. What do we need to do? We need to monitor. This is the one thing that we start patients on med, we forget, oh, they're doing so well, we forget to monitor all these different things. I'm not going to list every side effect that could potentially be a problem for these patients, but here are the most common ones: sedation, hypotension, when someone's put on some of these psychoactive agents. Then you have to remember to monitor for effectiveness. And you have to determine, is the behavior actually improving? Should we continue it? Should we not continue it? And how long would you give a trial of a drug? So you have to know how the drug works, how long it takes to build up in the system before you can get an effect. You have to give the drug an adequate trial. Then we, like I said before, look at compliance issues. Is the patient actually getting the medication, or are they spitting it back out and they're not getting anything, and we've left them on it for 3 months? Doesn't make any sense. And when you make adjustments very slowly. So you make changes only after the drugs reach steady state in the blood. I have physicians who forget sometimes that they want to make a change really quickly. And then I'm like, well, the drug has a half-life of like 6 days. So you're looking at, well, maybe a month before you should make a change, but they're making change in 3 days. Every 3 days they're upping the dose. So the poor patient by the end of 30 days is totally sedated. So we have to remember to make changes slowly. And increase doses only necessary. Never push doses just because you want to get a small incremental benefit. And then finally, always reevaluate. Have the treatment goals been met with this medication? If not, we probably should be stopping the drug. And then even if they've been stable for a while, we should consider tapering it, because that's the standard of care now. You don't just leave someone on a medication for all eternity because they did well on it for a short time. We have to give them a chance and take them off it, because as the dementia progresses or certain disease progression, you often don't need as much medication overall. And that is just a review of medication use in the residential care elderly population from a psychiatric background, actually. All right, thanks.
My name on it. Where did it go? Oh, here we are. Good morning. So I'd like to open with this statement. Any similarity between my outfit and the PowerPoint is completely coincidental. So I get kind of the fun part of the day. I'm going to talk about the impact of restraints as well as dignity and the practicalities around it. I've worked 20 years in residential care and in geriatrics, and so I'm going to give it to you from my perspective. So I'm going to review the definition again. What it says from the regulations is that any chemical, electronic, mechanical, physical, or other means of controlling or restricting a person in care's freedom of movement in a community care facility, including accommodating that person in a secure unit. But what's even more important than that is the fact that it is the effect the restraint has on the resident that characterizes it as a restraint, not its intended purpose. So if you have a resident in a special care unit and that actually facilitates their ADLs and their demeanor and their mood, then it's really not a restraint. But if you have somebody in a special care unit that is going to every door, every window, and wanting out, then we have restrained them. Does that make sense? So in other words, restraints include medications, devices, equipment, or aids designed to confine a resident's bodily movements or free body movements to a preferred position. So anytime they cannot do what they want to do, we are restraining them. So why do we use restraints? In 20 years, I have heard every reason. We have to keep them from wandering. We have to keep them from going in and out of other residents' rooms. We need to protect them from harm. They just might fall. We need to protect others from their behaviors. I'm going to steal an analogy from Dr. Robert Kane. I was at a conference where he was speaking, and he said, you know, you have your 25-year-old that takes his snowboard up Grouse Mountain or Cypress and snowboards all over, goes out of bounds, off a cliff, helicopter comes in, airlifts him out. Do we stop him from going up there again the next day and doing the same thing? We don't. He has the right to live at risk. It might cost him something for that helicopter trip every day, but he still has that right. For some reason, though, when we get to be about 65 or 70 years old, we can't walk across the room because we might fall. I might fall getting off this stage. So we have to consider, why do we want to do that? Why do we want to suddenly restrain people and keep people from doing what they need to do, what they feel they need to do? Preventing falls is probably the number one reason that I've heard. And I'm going to give you a case study and a suggestion of how you can approach that reason for using restraints. But I want to talk about the impact on that elderly person. I can go ad nauseum about this list, but as you can see, it's pretty extensive as to how restraints can affect a person. And so whenever a restraint is being suggested or requested by a care team member, I would suggest that you ask yourselves this question: who benefits? In whose interest is this restraint? Because more than not, that interest is the caregiver's interest, not the resident. And we hear the words, not enough staff. I can't be paying attention to them. They keep trying to get out of their chair. They're going to walk across the room and fall. So we need to think about what's the lesser of the evils that are going to happen. Do we want this to be the way our residents feel and look? I don't think so. I know I don't want them looking that way. So I suggest you don't try this at home. This is not an actual resident. This is one of our physiotherapists in Vancouver Coastal who did a great job. But I'm sure that if there's any nurses in the room that have worked in residential care, you've experienced this. I have more than once come across a resident that is strangling on a restraint. It's not something that I want to see very often. We think of bed rails. Well, these are some of the entrapment zones that we have with bed rails. You know, we have them on all our beds, right? Well, I've experienced some significant entrapments as well with residents, and it's been a fight to get them untrapped from those situations. So we really want to look at everything that we use. And there's things that we use in residential care, in care of the elderly every day that we don't even really think about. I know that low beds have now become the big deal in residential care. If you put that bed too low, what happens? They can't get out of it. We put that low at night so that what? So that they can't get out of the bed. The only reason I suggest a low bed is if that resident is actually at risk of rolling out of it, not getting out of it. So low beds are restraints. Brakes on the wheelchairs. We learned in school, nursing school. You park somebody somewhere, you put the brakes on. They can't take the brakes off, they're restrained. Grandma's sitting in a recliner. We got her nice and comfortable. She needs to go to the bathroom. She can't get out of the chair. She's restrained. All residents have the right to optimal freedom of movement and choice. The goals of maximum freedom are to optimize the resident's ability to interact with their own body, other people, and the environment. Acknowledgement and support the resident's autonomy and decision-making capabilities while considering the care processes and treatment issues, and to maintain or improve mobility and support dignity associated with living at risk. So what I suggest is that whenever there is an idea of using a restraint, think about why that person is behaving the way they're behaving. Because we know that every behavior has meaning. Everything we do, every instance, there's some reason why we do it. And it's the same for the elderly. It's the same for people with advanced dementias. There's a reason why. 9 times out of 10, when that resident is trying to get out of that chair, it's because they're what? Not comfortable, right? They need to go to the bathroom. They're having pain. They've been sitting there for 6 hours, and they want to go somewhere else. So let's look at that behavior and find out why they want to do that and address that before we do anything else. The legislation requirements. So we've got the definitions. The legislation has specific requirements, and I've been working with the working group with Vancouver Coastal for the past, how many years, Andrea? 4? To come up with a clinical practice guideline for least restraint management. We're almost there. But the legislation requires us to consider all alternates to resident restraint use. So that means if you want to use a restraint for somebody, you need to look at everything else that could be going on. Why are they wandering? Why do they want to get out of that chair? What else could be happening? If a restraint is to be used, careful and regular observation and documentation of the effect of the restraint is required. So it means regular monitoring, identifying how is this impacting this person. They might be sitting quietly this hour, but the next hour quite agitated and trying to get out of that chair or that restraint. We need to care plan accordingly, and that has to be documented. And ensure that the resident or the substitute decision maker and the physician are involved in the care planning and agree to the process. And then it's reassessing on a regular basis. So involved with this process, with the legislation, is a lot of paperwork. There's lots of paper. And nurses hate paperwork. Has anybody ever noticed that? They're always complaining, too much paper, too much paper. So I was director of care at a small facility in Fraser Health, and we were implementing the regulations, and the staff, the nurses were coming to me and saying, okay, we got to do something different. What can we do that would be different? We don't want to do all this paperwork. Like it's, the ongoing assessments, the changing of the care plan, the determining what interventions, there's just too much. So what should we do? So we met as a team. And what we did was remove every restraint from the building. So we did not have Broda chairs. We did not have seat belts. We did not have bed restraints. We did not have bed alarms. And we removed the side rails from the beds. If there was a need for a side rail at a resident's request or what have you, then that was assessed and then that would be put on. But it wasn't an automatic thing that our beds had side rails. This was a 76-bed facility. Prior to doing this, we averaged between 35 and 50 falls a month. Our population was quite ambulatory. It was about half and half intermediate care and extended care. So that was our average. We averaged 1 or 2 fractures a year. After we did this, we put a lot of processes in place, and we worked very closely with the falls reduction injury prevention team in Fraser Health, and looked at the falls. And we looked at why the people were wanting out of chairs, why they weren't comfortable, and we put many things in place. But at the end of the day, what happened was 2 years later, we were experiencing probably between 50 and 60 falls a month. Our fall rate did increase, but we had 1 fracture in that period of time. And that 1 fracture was an ambulatory lady who was walking through the dining room when an activity was going on, and the beach ball came in front of her, and she chose to kick it. And she fell down and broke her hip. That was the only fracture we had. So I challenge you to be bold. I've told this story many times, and I have had many people say, you can't do it. You can do it. It takes a team. You can't do it independently. It takes a team to put that in place. But these guys were motivated to not only make things better for their residents, but to eliminate a whole heck of a lot of paperwork. Thank you.
Thanks. Is this on? Thanks very much. Those were all very, very interesting, stimulating presentations. We have time for a number of questions. I would ask that you come to a microphone because the session is being recorded, and we want to be able to hear your questions, or people that watch after would want to hear your questions. Yes, there's one at the back of the room.
I guess 2 parts to the question. One was about the medication administration record that you mentioned for the drugs. Who is entitled to see that? And the second part was about the documentation in terms of restraints. Again, who is entitled to see the documentation in terms of the restraints being used? Are family members entitled to see it? Are advocates entitled to see it? Or is it a private matter that have to go through freedom of information?
Yeah, there's no easy answer to that question, is there? What's interesting about the way the law is right now, so the regulation actually says that there's agreement by the person, the family, and the representative. So what's curious about that is in the law in terms of the Healthcare Consent Act and Representation Agreement Act and the Comity of Person under the Patient's Property Act, it basically says, well, information can be shared with people who have the legal authority for that information to be shared with. I think there's if you're a family member and you're working with the healthcare team and they're asking you to consent to something, then of course asking to see it, or to agree to it, I should say. So if the family's being asked to agree to a MAR, then the family should be able to see that MAR, right? If the individual wants to see the MAR, then that individual should be given the MAR to look at it. If there's a substitute decision maker that I was talking about, the committee of person, a representative, and if they want to see the MAR, then generally it's shared. And it's generally, when you share information, it's for the purpose of, well, why do you need to see that information? So again, I go back to either if they're being asked to consent or agree to something, then you'll want to share that with them. But there's policies in each of the health authorities and that I'm sure apply to these types of decisions.
So is this on? Yeah. So as far as the least restraint regulations, that's actually a requirement that caregivers, families, or resident be part of the process. And so they would be part of the documentation and the paperwork all the way along. At the end of the day, there has to be a signed agreement to the care plan, to the interventions that have been trialed and eliminated or put in place. But that agreement is signed by a family or the family member, the resident, and the physician. So there is involvement with decision makers all the way along.
From a pharmacy point of view, we don't withhold information when the family is asking for that information. Often we'll hold a family meeting and go over all the medications. And by law, medication reviews have to be done twice a year for residential care. And usually those correspond with case conferences from what the facilities I've been involved with. And the case conferences involve the family. And so there'll be a whole team of people there, all the different caregivers as well, and everybody will give their input, and then the family has opportunity to discuss all these different things. So I've never come across an instance in this type of setting where we're withholding information about the medication. And in fact, that would be actually, I can't imagine a situation where we would do that. We'd probably just get the family really angry at us. So that's the last thing we would want to do, actually. So, yeah.
When these case conferences are held, is the family given any information prior to the case conference, or are they just presented with the information when they arrive for it?
That's going to depend on the facility and their processes. What I recommend is that what I have done as a resident care coordinator is actually have a discussion with the family in advance, giving them kind of a heads up and allowing them the opportunity to put together their thoughts, giving them an overview of what's going to happen at that care conference and what kinds of things are we going to discuss. Does that answer your question? Medications in advance, that typically not. What will happen at the care conference is there will be that, as I said, there'll be that discussion and a review of all the medications that we're on and at that the resident is on, and at that time, the family member would have the opportunity to ask why. Okay.
Could you tell me the name of that facility where all the restraints were used or were removed?
Sure.
Pardon me.
It was Pleasant View Care Home in Mission. And I also did a partial purging at Mission Extended Care.
Okay,
It's funny about restraints, though. It was like they were breeding somewhere, because every month I'd go through the closets and find more. And I wondered, where did they come from?
Right. And also, can you tell me, when you did that, when that project was underway and you removed the physical restraints, during that entire process, did you take into account chemical restraints? Because, of course, chemical restraints do actually cause falls and injury amongst many other things. So
you're absolutely correct. Chemical restraint is something that in residential care we've been very slow to get onto. Somewhere along the line, my chemical restraint slide definition got eliminated. But it's just now that we're really having a good look at how we use anti-psychotics and where it's appropriate. And I think that there's another discussion coming up about the actual use of the chemical restraints.
Okay,
but in our facility at that point in time, no, we weren't going there. All we were doing at that time was recording all our PRN antipsychotics that we were using.
All right. And a question for, it's Leanne Hospital, the public guardian. Does a public guardian only take action if you're comity of the person? Action on medical issues, medical care, abuses by long-term care facility?
Generally what we do is we receive a referral from a residential care facility because maybe there is a representative or a private committee, so a person who has gone to court and is a committee of person for their family member. And we would get a referral saying that they're not acting in the best interests of the person, and we would investigate that.
Okay. So do you ever take action, or you just investigate?
The action would be we would investigate, and we're kind of looking at it more as what is the problem at hand, and working with the substitute decision maker to resolve that problem. Sometimes it's from a place of ignorance or just not knowing or understanding their duties and responsibilities. So there's an education around that, but failing that, and if it's particularly egregious and we have evidence to support that, we could go to court as well to remove that substitute decision maker and become one ourselves. Okay. Or even recommend if there's another family member, because sometimes one family member has the authority to make decisions, and then there's someone else who may be interested. They could go to court and go that process.
Okay. And have you ever gone to court to intervene on behalf of allegations of abuse against family members, against care facilities, anything
yes, we
like
have.
That? You have?
Yep.
And is that information available anywhere?
In terms of what kind of information would you be looking? What kind of information would you be looking for?
Well, for example, when you go to court records are available, and in other provinces they do publish tribunal decisions and so forth. So I was just wondering if that was available. I don't think we have it on. We don't have court decisions on our website, but I suspect, I know if it's at court, then you might be able to search under BC Laws. But
website.
You don't provide that?
No.
No.
I'm sorry?
The court orders are public.
Mm-hmm. Yes. You don't
That's right. We don't have court orders on our website, but court orders are public. Yeah.
Mm-hmm. Okay. All right. And so you mentioned earlier that you're not all that familiar. Does the public guardian get any training on, do they have any medical experts, or do you just make these decisions like any other member of the public? Pretty
much. I mean, we refer to ourselves as informed decision makers. We're not medical professionals. And that's not the goal of a substitute decision maker. A substitute decision maker isn't an expert in the field that they're making decision in. They are the people that are asking the questions, that if a family member was able to, those are the questions that they would ask. Again, like, what are the alternatives? Why is this necessary? It's, again, coming from that, a caring place, but also, we call ourselves informed lay people just simply because we do get asked, so we build our knowledge, but it's always the same approach. We're looking at making a good decision, under the best interests of that person, according to the laws that we're working under.
So the substitute decision maker's authority is supreme, or can someone else overturn that?
I love
if
that
they
word,
have a
supreme.
concern
That's
about
good.
the medication. I'm sorry, I didn't hear that.
I said I love being supreme.
Well, no,
so
I'm just wondering on behalf of ordinary citizens who are substitute decision makers, do they have to be concerned when there are concerns about the medication, for example, like the pharmacist just explained to us, when they raise concerns and they are dismissed by either care staff or other agencies?
Well, that's a challenge. I mean, that's an advocacy, issue. I mean, I think the instance is there's a family member who has an authority to make decisions, but they're not involved. I mean, I think from a best practice perspective, involving people in those decisions is your best bet. That is the best approach. But that doesn't always happen. I mean, and the public guardian and trustee often gets those calls because the communication is broken down, and sometimes we'll help facilitate that just because we're getting the call. But it's work. If the person has legal authority to make decisions, the trickiest part is when the decision is being asked to be made and they don't agree.
And why is that tricky? Do they not either they have the authority or in law or not?
Well, I think it's tricky for the healthcare provider, right? So if you're the nurse or the doctor who says, I think you would benefit from this treatment, and the substitute decision maker says, no, what happens then? That's the tricky part.
Well, does the healthcare provider who's wanting to drug the person have the greater authority then?
I'll talk
this is
from
an interesting
experience,
debate.
Maybe from the ward I work on, and it's kind of the complicated ward where you'll see a lot more meds normally than what you would see in residential care. When a family says no, we basically don't pursue it further because we know that that's the final bit. I mean, if a patient was actually more psychotic and a super danger to patients around them, they may start very, very low doses of something. But I've seen cases where the families come in our care conference said, I don't want my mom on anything because she can't tolerate anything, and we'll give them a trial. We'll work with them for a while, and they'll still say no, 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 and it ends up, okay, nothing. We have patients sometimes in that facility with nothing, and we're just managing the best we can. And I would say from experience, most of the doctors don't want to go against the family at the ultimate time.
Okay, except that I work with a lot of families where that is absolutely not the case, and where they are aggressively disputed when they bring concerns to their attention, even when they have other doctors backing them up. And so that's why I wanted to get some clarity around the law for people attending here, so that it could help everybody. And I know that the public guardian, I'm not sure if you're a lawyer, but the public guardian has a number of lawyers, and I would have thought they could have answered that question, since they are the final arbiter apart from the courts in BC.
No. We're not the final arbiter. Actually, under the Healthcare Consent Act, if there is a dispute about a decision, the health authorities can go to court about it.
Yes, but a public guardian has the authority to take away the rights of a person to manage their finances or their person. So in that sense, you carry a great deal of weight and power and authority, and so you're second only to the BC Supreme Court. In this
I'm just going to interrupt here. This is a really interesting conversation. I think there are other people that want to speak, and I think also that some of these issues are going to come up in the next presentation. So we'll just keep moving. We have a few more minutes. Thank you.
My name is Doug Johnson. I'm from Fraser. I'm a volunteer there. I just want to go off topic just for a second. I want to talk to Lisa Marie about. She gave a very interesting presentation on pharmaceuticals, how they're absorbed and everything else. Fantastic. The one question I have for you, at Fraserview, we're realizing that we're getting a increase in the Asian population. And I don't know if you're familiar or not, but the Asian community has their own feeling about pharmaceuticals. Pharmaceuticals are a Western style of doctoring or medicating people, and the Asians have their own herbal. And what Fraserview is experiencing is that families are now bringing in herbal medicine for their grandparents, and it's something that needs to be monitored and is impacting your pharmaceuticals.
Oh, yes. Okay. I have actually a very interesting case right now. We have a lady who the husband went out and purchased something from Korea, some seaweed of some sort. And I had to make the determination whether this was going to affect the other drug therapy that she was on. And I was more worried actually about her thyroid because she was having thyroid issues at the time. But I worked with the family, with the daughter, and they want to still spend the $1,000 for that they were buying from overseas, this herbal drug seaweed thing. And I've allowed it, and the doctors are on board with it, as long as it's not impacting something that we're not familiar with. I went online and did some research and dug up some papers and basically found that it's an antioxidant. There's really no known side effects. However, we are worried maybe about the iodine content in it with regard to her thyroid, but we're still monitoring all of that. So you actually, when you have all these other herbal medications, you have to, it's another thing to monitor and another thing to worry about. And we tried the best we could to prevent him from purchasing this $1,000 supplement per month, but he's adamant for it, and we're not going to stop him if that's what he really believes in. We didn't see the harm in for the patient because she's actually on a small number of medications overall anyways. But yes.
Yes, what does the panel think is the biggest systems issue that needs to be addressed to solve this problem?
Which problem?
All the problems.
The overuse of restraints, be they chemical or physical or whatever.
What has to happen? It is about mindset. It's accepting that we can be different and being different and addressing the actual issues of why the behavior exists. the current frame of mind is that that's time consuming and we don't have enough staff. I've heard that over and over and over. We aren't getting any more staff. And so we have to look at the way we do our work and do it differently. It was a challenge at my facility to actually remove all the restraints. It took a huge shift, but everybody was on board and everybody knew what the next step had to be. We posted graphs of the times and the locations of our falls. We identified where we had to shift our schedules so that we had more people at those times that seemed to be higher incidences of falls. We increased our rounds on nights so that every resident was visualized every hour. So it is a mindset, and it's shifting from our current practices that have been in place for 20, 30 years. So it's grassroots. It's at the very bottom that change has to happen.
I just wanted to make one more comment. I had a patient recently come to us on 27 medications. And the nurses were complaining to me, oh, he's so agitated, he's not doing well. And I said, well, how much time are you actually getting to spend with the patient? And the response with me, well, I don't spend much time with the patient, the care aides do, or the rehab worker. And I'm thinking, okay, so here our poor nurses are running around giving 27 medications to one resident. And that's not just all in the morning. That's 27 medications divided throughout the day. So they could be getting them at lunch, supper, bedtime as well. So we have to change the mindset that our nurses just give meds and document and do blood pressures and vitals and run the unit. They need to also be involved and with the patient. So that's what I'm advocating at my ward at the moment and hoping to make some change. I mean, there's always, you're going to have people saying, oh, we can't do that. And that's what I've come across because I'm newer to this setting. But I'm just persevering and hoping that if I'm a bug in someone's ear, someone will eventually listen to me. So you just have to keep trying.
I'll just make a brief comment. I see we've got a person that wants to ask a question. I think we really have to look at person-centered care and the PIECES approach and do individualized care planning. So I know there was some discussion yesterday about this sort of the system that serves the service-oriented and person-centered system, and I think that's a good place to begin. And I see there's a person with a question at the back, and I think we have time for probably 2 more questions.
Thank you. My name is Jerry Gosling. I'm from Costco, and you have said that the family members should be present in the distribution of knowledge for the resident. Would a family member be welcome at the meeting with the doctor when he meets with the staff of a residential care facility?
I'm going to take it back to my previous answer, and it's going to depend on the facility and their attitudes and their beliefs. From my perspective and in my facilities, I welcome the families. The more difficult, the better I liked it. Because I got a charge out of swaying them. But in care conferences where the physician is there, and typically it should be the medical director and the GP, pharmacist, dietitian, recreation, physiotherapist, nursing, they should all be at that table with the family. Yeah. And the family's free to ask whatever questions they need answered. So yeah, they should be there.
Yes, well, it could vary with each residential care facility then, right? Thank you.
Can I just one more comment to that question? Ask the questions. You can ask, why are these people not here? Or why am I not included? And find out what the answer is.
My question is about cognitive problems and the number of medications that people are taking. We had an elder in our family who was diagnosed with vascular dementia. And to make a long story short, in the end, it turned out that she had a drug interaction called serotonin syndrome from an SSRI and a pain drug called tramadol. I'm just wondering, from your point of view as a pharmacist, how much do you think that some of the diagnosed dementia or worsening dementia might actually be delirium or adverse effects from drugs?
Probably one of the main things we're taught in school is that before you label someone with dementia or delirium, or you figure out that they're in a delirium, you're supposed to review their medications and any changes that have occurred in the recent few weeks. I'm actually probably going to be starting a study on anticholinergic load, which as a pharmacist, your job is to always look at the possibilities. And you're right, a lot of the times the medications are contributing to cognitive difficulties, problems. So I don't know a good psychiatrist or a good geriatrician who diagnoses dementia should be able to recognize that. However, that being said, I think there's flaws in the system where the healthcare providers are trying to do so many things at once. They feel like they rush things, and there's not always the resources to to have a pharmacist there or to have a team there. And that's where people fall through the cracks. And that's why I love the families. Actually, I love it when the families are kind of upset, because I know that we'll have greater success in trying to get people off the medication. So I would be an advocate for my family, as all of you would, go to the team and definitely voice your concerns and be an advocate for that patient who can't speak otherwise, because you always need to be looking what else could be causing this.
Thank you so much. Thanks very much to the panel. We are going to have to cut it off now.
There's
a related discussion.
One comment, and that is that I think the family is very important to be involved because they know the baseline of the person, and the people who are treating may have just met this resident.
Thank you so much. Okay, thanks everybody for that discussion. It was great. Thanks to the panelists, Leanne, Alyssa Marie, and Susan. It was a very, very engaging, stimulating discussion.